Hi, my name's Carly Newbold, and I'm the new stroke coordinator for Dominican Hospital. And I just wanted to add a few things to Dr. Markert's video, just trying to give you guys some tips and hints for the stroke population that we see at Dominican. First, I want to thank you guys all for the work you've been doing, especially the last 2 years. It's been an extremely hard with COVID. I just started this role, so I was on the floor gearing up in the space helmets and all the gear, and I know how much more complicated it is with our COVID population. And I really want to take a moment to thank you for all the work you've done, because I know it's been immensely stressful out in the field, and you have limited resources and probably staffing shortages as well. So first of all, thank you. Now back to just adding a few things to the video that you may have already watched or will be watching after me. Dominican Hospital is our primary stroke center for the Santa Cruz County. So we take in everything that can be treated possibly with TPA. So we have a window of up to 4.5 hours from last known well. And that's where you guys come in and where you're really important, as if you know of a clear-cut onset. Like Dr. Margaret had mentioned, if you see a clear-cut onset and you can call us and let us know you have possibly stroke coming in and that we should wheel them straight to CT, time is brain. So with that being said, just a few other things to add. When you're out in the field, some of the risk factors, the most important obviously being hypertension. Are they a smoker? Are they a diabetic? Do they have hyperlipidemia? Are they obese? Do you have that history of AFib? Have they had a prior TIA? Because in 15% of cases, a prior TIA can happen in a stroke patient. Or do they abuse alcohol or methamphetamines? And we do see occasional patients here with methamphetamine use. So that should kind of clue you in, hey, this is more likely a stroke, because I hear David, their husband, talking about these risk factors. And then other things, which this may or may not be a review for you, so I apologize if it is, as Dr. Margaret had mentioned or alluded to in his video, is the timing. Anytime you see sudden weakness of the arm or leg, sudden confusion or trouble speaking, sudden problems with vision, sudden trouble walking, dizziness, sudden headache, that is actually really indicative of a stroke. With a lot of the stroke mimics, and I know mimics can be a huge problem, it's still a problem for me discerning the inpatient. The biggest difference is usually in the anterior strokes, those MCA and anterior vessel and middle cerebral artery strokes that are easier to discern, is that the sided weakness is usually sudden. In the posterior strokes, it's a little more muddled because the symptoms are vaguer. But if you hear sudden onset, that should clue you in, hey, this might be a stroke. And that might help you with the stroke mimics. And some of the common stroke mimics are brain tumors, migraines, seizures, Bell's palsy. One way you can tell if it's a Bell's palsy or if it's probably a stroke is the facial paresis. If you see that weakness and it's extending all the way up to the forehead and including the forehead, it may not be a stroke, because strokes usually present more with lower facial paresis, and Bell's palsy has whole facial paresis. So you might want to look at where the facial paresis is presenting. Also, sepsis or any type of metabolic disorder. Also, a big one for you guys is the high or the low blood sugar. So if you get a really high blood sugar or a really low blood sugar, that might be, this may not be a stroke. It might be something to do with their blood sugar. So if blood sugar is 140 to 199, even if they're diabetic and they haven't had problems, that might not be as much of a clue, but it helps you figure out, hey, this is a stroke or isn't a stroke. So those are just some reminders and tips. Part of the reason this is so important is even if they're out of that 4.5 hour window, It's still really good to call a code stroke if you're like, oh, this definitely seems like a stroke syndrome, if you have a clear onset time, because we can treat them for up to 24 hours. We're not thrombectomy capable, but we do send quite a few patients to Stanford. The doctors have an app on their cell phone, like most people have apps all over their cell phones, called Rapid AI. And it gives us the CT perfusion images. So it will tell us from the core versus the area of ischemia, which is an area where the blood flow is greater than 6 seconds or is less than 30% volume. And if that penumbra is somewhere around 60% or so, depending on what the neurologists at Stanford and our neurologists see, we can transfer that patient for up to 24 hours, especially for those large vessel occlusions, that middle cerebral artery and anterior cerebral artery, and get them treated. So the quicker you can get us that patient and say, hey, this is a code stroke, it really does help us, because we have sometimes issues with the helicopters because of fog or the mountains. So if we can save time on the front end, it saves us time on the back end. So I hope those little tips were a little bit helpful. And I just wanted to read one or two case studies. Now, I wasn't creative enough to make my own, so I used these from American Heart, so I have to give them kudos. But I'm just going to read a couple case studies and then let you guys go. So one is, this first one is a middle cerebral artery one that got transferred. So she was a 65-year-old patient. She had had a cholecystectomy 3 days prior. She was normal at 10 p.m. before she went to sleep, and she woke at 2 a.m. by her husband with aphasia and right hemiplegia. You guys brought her to the ED at 3:15. Now, she wasn't eligible for TPA because she's outside that 4.5-hour window, and also because she had surgery just recently, just 3 days prior, and her NIH was 19. And now her CTA and her perfusion confirmed that she had a left MCA M1, and she was able to be transferred, we'll say, to Stanford, and she had a mechanical thrombectomy that was successful, and she was discharged home. 3 days later, after having an MRI that showed she had no infarction, because we got her up to Stanford 24 hours later. All right, so that's one case study for us. Okay, so now one more case study. Maybe we'll just do one because I want to keep you guys here all day. And you can always email me with questions. Another case study, this one is a younger person. There's a 20-year-old man, and he comes to our primary stroke center at Dominican. And he had left-sided weakness and imbalance and a decreased level of consciousness. Now, that left-sided weakness and imbalance, that's more indicative of posterior, like Dr. Markert had mentioned. His CT showed no hemorrhage, but he had a hyperdense basilar artery, and his CTA, his CT angio, showed a mid-basilar occlusion. He did receive TPA because he came within the window, and he underwent a mechanical thrombectomy for his right basilar artery. 2 days later, he was discharged home, and 3 months later, he was normal and went back to college. So here's just two case studies, and we hope that these two short videos helped you guys. We know it's been kind of chaotic, so we wanted to keep it short, and obviously kind of with the way things are going, we did this via Zoom, but hopefully in the future you can always reach out with questions, and we hope that we'll be able to provide you with some more information anytime you need it, and some more updaters and refreshers in the future. Thank you so much, and have a good evening or good day. Take care.